Griffin do our December meeting for us. It's kind of a tradition, and we appreciate that you have come to talk to us and continued our, I don't know how many editions, but I've been doing this for like 10 years, and Griffin's always been our December speaker.
So we just screwed it up.
So we always try to promote something that Griffin is participating in, or any new programs or doctors that we can kind of highlight, get the information out to our team. So we appreciate. If you don't mind, I'd love to introduce you with your information up here.
Sure.
Okay, so Dr. Salzano.
I'll give you the next slide.
is born and raised in Hamden, Yale University bachelor's degree in 1984, and then on to University of Rochester in 1988. Continued with a hospital general surgery residency in Hartford, and then to the University of Rochester for a thoracic surgery residency.
Yeah. So
And on and on
this is
and
how you
on
get,
and on.
so this is how you get, that's how you get to be me. It's a long, I didn't start working for real until I was 33 years old. So it takes a long time.
How many total years of school was that?
Well, it's so 4 years of college, 4 years of medical school, then 7 years of residency. So, you know, so it's a long process, but it's very rewarding. Obviously I'm born and raised local. My wife's from New Haven, and we always wanted to come back. So I came back to New Haven, and I won't go through the details here, but the idea of my career has been, I started off as a heart surgeon in New Haven, coming to Griffin. And then as things transitioned in New Haven, I transitioned my practice to Griffin as the chairman of surgery. I'm also responsible for all of the in-house Griffin thoracic surgery. So I do robotic surgery. I do any of the lung cancer surgery. So, and I also have privileges at St. Vincent's, and I also do some wound care at Griffin as part of my responsibilities in the Department of Surgery to sort of help out with the hospital. So today I'd like to go over lung cancer screening, and I want to, so first of all, informal here, just, you know, feel free to ask questions, but chances are I'm going to answer a lot of the questions. So when I give these talks, I kind of want to, there's always two things to sort of set the mood for everyone. The first is that for many of you, maybe most of you, this does not apply to you. Okay, if you don't have, this is for a very specific group of people, and I'll go through that with a very specific smoking history. So a lot of people, this doesn't apply to them directly, but I'm sure that all of us have someone in our lives, whether it's a family member, friends, coworkers, who do qualify for lung cancer screening. And what I have learned is, and we were talking about earlier, we need to have a grassroots campaign here. We need to get the community aware, get everybody involved, because I hope I'm going to prove to you the importance of this. And the second point sort of related to that is to keep in mind, and you know, smokers have become marginalized in our society. Okay, these are not people who are coming forward. Okay, there's almost a shame or an embarrassment in our society now with smoking, and there's also this idea of, well, you did this to yourself, or just quit, or whatever, and it's not that easy. Okay. And I think we have to think that way about these patients. We have to understand that these people, a lot of times, who are qualify for these programs, for this program in particular, are somewhat reluctant to come forward. So it's inherent on us to help them and to encourage them. So that's why I think it's important, even if this doesn't apply to anyone in this room directly, it applies to everyone in this room in some way. Okay, so just keep that in mind. So, you know, what's the problem? Well, smoking is just, has a tremendous effect on your lungs, and, you know, there's scarring, there's restriction, and it really affects breathing, but it also affects risks. Okay. And, to understand lung cancer screening, let's talk about lung cancer so that you understand lung cancer. So there's 250,000 new cases a year in the United States. And there are 160 cancer deaths a year. So on an average, 18 people an hour die of lung cancer. Now, they don't die, it doesn't happen that way, but it just gives you a sense of the, the magnitude of the problem. We know that from either current smoking or past smoking habits, there's upwards of 100 million Americans who are at an increased risk for lung cancer in our community, okay? It is the most common cancer death. It's not the most common cancer diagnosis, but it is the most common cancer death. And it is in fact more deaths per year from lung cancer than breast, colon, and prostate combined, okay? And until recently, we haven't had any ability to find these patients, okay? Now, cancers are all staged according to how extensive the tumor is. And this is important to understand why we need this. And I'll show this graphically on the next slide, but the basic idea is that stage 1, 2, 3, 4. Okay, stage 1 is a tumor just in the lung. Stage 2 has only spread within the lung. And stage 3 has gotten out of the lung, but in the chest. And stage 4 has gone to other parts of the body. And you can kind of see this graphically here. And let me see if I can use my pointer for the people at home. The idea is early and limited means it's still in the lung. It hasn't gotten out of the lung, okay? 3 and 4 are out of the lung, so they're more advanced. And so think about it in terms of those two groups, early and limited, advanced and metastatic,
Does it
okay?
matter in staging if it's in one lung or both lungs?
It does. When you get into both lungs, it's usually advanced stage. Okay, so if it goes to both sides, okay. And again, this is a little bit simplistic, but it's the basic idea. And these cure rates have held up. These cure rates have been the cure rates forever, okay, and they're not really changing that much, except for some of the advanced cancers. But all in all, in stage 1, you can expect to cure 3 out of 4 people. And in fact, in some groups, and we'll talk more about this, you can cure 9 out of 10 people, okay? Stage 2, it's more advanced, so it goes down to more like 2 out of 4. So 3 out of 4, 2 out of 4. Stage 3, 1 out of 4 can be cured. And then with stage 4, we used to say that they were more likely to be miracles, okay? But we're seeing now in the last few years with these new drugs that we have, you're seeing it on television, Opdivo, Keytruda, those types of drugs. We're seeing things that we haven't seen before, but some of this stuff is still bordering on miracles when we have advanced cancers that are being cured. And this slide is always, people sort of are surprised by this, but I want to point out a couple of things here. This is 5-year survival, okay? Survival and cure are 2 different things, okay? So survival means you're alive. And when you look at this and you say, well, how can this be for breast and prostate? Well, breast and prostate cancer, there are a number of patients who will have advanced cancers who remain alive but are not cured. The difference with lung cancer is if you're diagnosed and you're alive 5 years later, you don't survive without being cured, okay? So it's a different biology, but it's also a difference of, let me see if I get my pointer working. PSA, mammography, and colonoscopy. And that really has had those kinds of effects on those tumors. Okay, so we know that if you just take the community, no lung cancer screening, all right, 3/4 or more of your patients are going to be in that advanced cancer, okay, at the time of diagnosis, which means that we have little or no chance to cure them, okay? On the other hand, we know that the earliest tumors, very small in the lung that haven't spread anywhere, we can achieve 90% cure rates. Now that's remarkable. That is as good as any solid tumor cancer for cure rates. But why is lung cancer such a bad thing? It's because of that first point. And we need to find cancers earlier. So that's the idea behind coming up with screening. And until 2011, we did not have anything to go with. And then comes the National Lung Screening Trial, which is the lead article in New England Journal of Medicine. That means everybody's got to pay attention to it. This is, New York Times kind of stuff. Okay, and let me just describe it to you so that you understand. It was funded by the NCI and it was a randomized trial. So what that means is, if you agreed to participate in this, what they said was, listen, we don't know what's best for you. We don't know if a chest x-ray is as good as a CAT scan. Maybe there's no difference. Maybe one's better than the other. So the study is going to be, we flip a coin. Okay. If it comes up heads, you get a chest x-ray. If it comes up tails, you get a CT scan. All right. And people need to understand, and I can see sort of the looks. This can only be done if we truly don't know the answer, because it's unethical to flip a coin taking care of patients, right? So if you are going to do this, it has to be accepted that we don't know the answer, okay? So they took patients for a couple of years, and I took this right out of the document, which says to determine whether low-dose CT, and I'll tell you about that in a couple of slides, as compared to chest x-ray, would reduce death from lung cancer among high-risk persons. So a very specific group of people. So it doesn't apply to just everybody, all right? Just a very specific group of people. And that group, as defined by them, is a very specific age with a very specific smoking history. Now, 30 pack years means, so what you do is you take how many packs a day for how many years, okay? So 30 years of 1 pack per day is the same as 15 years of 2 packs per day, etc. Okay? And you either had to be currently smoking or have quit within the last 15 years. And they excluded people with a history of lung cancer because they thought that might complicate things. And they also exclude people who are symptomatic, because you don't screen people who are symptomatic, you work them up. Okay? So this is for people who we have no other reason than their smoking history to scan them. Okay? And I can tell you that 53,000 people enrolled is ridiculous. You're lucky if you can get 100 people in these types of trials. So to get 53,000 is just remarkable. Okay. And this is, so again, I said earlier that, this is technical. All right. This isn't my usual good housekeeping presentation, because I know this is a sophisticated group of people, but you don't have to have an MD degree to look at this and know what it means. Okay. So on the top, and this is right out of the document. Okay. So on the top is number of lung cancers screened, the number of lung cancers found. Okay. And remember, because of the randomization, because of the coin flip, if there's no difference, these lines should be identical. All right. Because you've eliminated all of the differences by flipping the coin. So you can see in the top that the patients who get a CT scan, we find a lot more cancers. But look at the bottom, that's where the home run is. We save lives. Okay. That's death from lung cancer. And you can see that that is a lot lower in the CT scan group than in the chest x-ray group, 20%. Okay. So again, you don't have to be a doctor. You tell me which group do you want to be in, right? It's pretty obvious. And, they actually ended this study because the results were so overwhelming that it was no longer ethical to flip a coin. You couldn't go to patients and say, we're going to keep doing this, because now it's obvious. Okay. So what you need for a screening program, first of all, you have to truly do a low dose CT. So what does that mean? All right. We have a way to measure radiation. It's called millisieverts. That's how much radiation you're exposed to. So a usual CAT scan of the chest is about 8 to 10 millisieverts. So this scan is 1.5. So what does that mean? That's the same amount of radiation that you would be exposed to if you took an airplane from New York to Los Angeles. Okay. So when you put it in those terms, it kind of calms people down in regards to, am I going to light up like a light bulb, or is this so much radiation that it's going to cause cancer? So the answer is no. All right. But you do need radiologists who know how to read these scans because they are a little different than a usual CAT scan. So they have to be tuned into how to look at these things, okay? You need everybody to buy in. We've got a team, okay? And the rest of our team includes my pulmonary colleagues, who many of you know, like I say, dedicated radiologists, and all of our doctors in the cancer center, along with our support staff. We really feel, all of us feel that if you're going to do this to improve your community, you need to have a smoking cessation program as a part of this. And we do, and we've got some information on that, which again, you can bring to your friends if it doesn't apply to you. And you need to be able to follow people. You can't let them get lost, okay? And that's why we're a team here. We've got a lot of resources and things that go into that. Hey, Bill. So just to give you an idea of how this played out, and I want you to remember the spring of 2012, because that's important on a couple of more slides. So we talked about this in the spring of 2012, and it took us a year and a half to get up and running. It was really a long process. You don't just snap your fingers and have a lung cancer screening program. But once we got started, it really took off. And you can see on this graph, this is our early experience, and we found our first cancer very early in this program. And as I say, I think a lot of this had to do with the community really buying in on it, both the professional community and the lay community. We really saw a lot of interest and enthusiasm for this. So what does it take to be eligible for this? So it's changed a little bit. When we first started off, we stuck by the NLST with a little bit of a modification, okay? So remember that slide, 55 to 77 with a 30-pack year history. But we also said, maybe this is good for people a little bit younger, a little bit older, a little less smoking history, but maybe they have some other risk factor like COPD or a family history, or they've been exposed to radiation, okay, or some occupational exposure. And then the U.S. Preventive Services Task Force analyzed all of this data, and they came out with a grade B recommendation. Now, I'm not going to go into the details of what that means, but let me just say that grade B recommendation is the same recommendation for mammography, okay? So the government agency that's responsible for reviewing this feels that this is as important, as impactful as mammography, okay? And what they came up with was this age, 50 to 80 years, with a 20-pack year history, and either currently smoking or within the last 15 years. Now, this is a moving target right now. The American Cancer Society? The American Cancer Society recently made a recommendation that we drop that quit within the last 15 years, so that this should apply to everyone with a 20-pack year history. That hasn't been accepted yet by the insurance companies because they realize that that's going to cost them some money. But we're hopeful that it takes some time, but we're hopeful that with some community pressures and professional pressures that we can get them to that point. So this will increase the number of people who are eligible for participation and continuation in the program, okay? So, it is mandatory that you be referred to the program. In other words, you can't just call up like mammography. The only requirement is you be a woman of a certain age, and you don't even need a doctor's order. You can get your mammogram back. This is different for a lot of reasons. It's a more complicated decision, okay? And they feel that they only want eligible patients, number one, and number two, patients who are suitable for processing, okay? In other words, you know, they've got the health to go through this if we say, hey, we've got lung cancer and we have to cure you. All right, so it's really mandatory that what we call shared decision making, which means that they come into the office, their doctor talks to them, they go over the risks, the benefits, and the appropriateness, and then put them through, okay? you really need to be strict about your enrollment and your participation. Otherwise, the insurance companies will not allow you to do this, okay? We have our coordinators, navigator. Joanne is the person who, follows up. She keeps track of everyone in the program. She follows up with them. She communicates with them about what their scans are, what's gonna happen. We'll involve people like me, Dr. Chase and Dr. Spivak, et cetera, when someone has a finding so that we can explain that to them. And as I said, smoking cessation is really important with this. And what we have here is, and you might, for anyone who sees this, we need a system so that I don't have to look at every scan, okay? So the radiologist grades them 1, 2, 3, 4, okay? 1 and 2 mean you don't have to worry about this, see you in a year, okay? 3 means, there's something there, but we're not too worried about it, but let's not wait a year, let's wait 6 months. And 4 means you gotta pay, you gotta hone in on this because this could be a cancer. Now, what are for all of the lung rads 4, it's called lung rads is the name of the grading system. All of the patients, so they'll come into the office if they have a 4, all right? And we'll tell them that don't jump to conclusions here. The chances of this being a cancer are about 15% at the most. But again, there's certain ones that are obvious, okay? But that's the idea, to get these people identified and processed correctly. So what do we know from our research? What could we expect? Okay, so there's another study which I'm not going to spend any time on because it's a little different than NLST, but LCAP taught us that if you find 1,000 patients who are suitable for lung cancer screening, on your first scan, you're going to average 11 cancers. Wow. Okay, so of those 1,000 people, you're going to find 11 lung cancers. And remember, these people are asymptomatic. There's no reason to look at them. All right. And if you keep following them every year, three of that group will go on to develop lung cancer. So those are the numbers. It's not overwhelming. So this is the important thing. People don't need to be afraid. And I'll talk, if we have time, I'll talk a little bit more about that later. Some research that we did at Griffin. People don't need to be afraid. They don't need to feel like, oh, this is just going to be bad news. Okay. But this is real. And I'm going to show you a scan of someone that you're going to go, wow, good thing. Okay. The other thing that we know, and this is also important to tell people, that 1 in 4 people are going to have something. All right. They're going to have something. Now, but 96 out of 100 of those are going to be nothing. Okay, so again, these are just to sort of allay people's fears about being in this. It's not going to necessarily be bad news. Okay, so I want to go through a couple of things here, which listen, I'm going to brag. I'm going to brag about what we've done. Okay, but I think it's important for people to see what's going on here. A couple of things. So first of all, let's start with some information. Like I said in the beginning, if you look on the left and the right, so left side is, let's look at our entire community, everybody, and see what the stages are of lung cancer staging at the time of diagnosis. And as I said earlier, about 3/4 or more of those patients are advanced. Okay, so the orange part of the pie there is advanced versus the gray part being limited. Now on the right side, this is what we know from all of our research and literature, that in lung cancer screening, so specifically the patients who are in lung cancer screening, excluding everybody else, that's a mirror image. Okay, that 3/4 or more of them are limited. And remember, those are the patients that we really can affect, that we really can cure. Okay, so this is from academics literature. Okay, so what I decided to do was look at our early results. Okay, so this goes back to 2015, I looked at our early first results, and in our group of patients that were first screened, we found 9 cancers, and that's how they break down in terms of stages. Okay, you can see that at the bottom, if I can get the pointer working here. 78% early stage, 22% late stage. Okay, so then I went to our cancer registry, which the cancer registry is part of the hospital's cancer center. They tabulate and follow everybody in the Griffin community who gets diagnosed with cancer. Okay. In gray is the lung cancer screening by stage. Okay. And in orange is everybody else diagnosed with lung cancer. And you can see the mirror image. Okay. Now, this is important. All right. And this is the strong point to be made. You don't have to go to Yale. You don't have to go to Hartford. You don't have to go to Memorial Sloan Kettering. Okay. Griffin Hospital can do this. It works. Okay. And nobody needs to think that, oh, well, I should have my scans done somewhere else. We did this. Okay. We can replicate the big study. Right. We're doing it. Now, remember what I said earlier about 2012. So that's when we started talking about this. And I still was a heart surgeon in New Haven. So I wasn't part of the formulation of this, but I was brought in early. I'm told that this picture here is what prompted March Deegan, who many of you might know, who's a former VP, to say we need a lung cancer screening program. So this is a report from the Commission on Cancer. So this is a body of the American College of Surgeons. They review your cancer center every couple of years to see how you're doing and to give you an idea of what you're doing compared to everybody else. So this was our report for lung cancer staging in 2012. So Griffin is in blue, and everybody else, the rest of the country, the rest of the group is in black. And what you can see here is that we're not, if I can get the pointer going, we're low on early stage, and we got too many advanced stage. Okay, now I'm gonna go back and forth here. So, all right, this is 2017. All right.
Wow.
So what I can tell you is from here to here, okay, it's the same hospital, the same doctors, the same CAT scanner, the same patients. The only thing that's changed is lung cancer screening. Okay.
Awesome.
It works. All right. And remember, these are the patients that we can cure. These two here. Okay, so it works. It works. Now, this is our last few years, and it's kind of holding up. Okay, this was 2015. We found 9 cancers that year, and again, you can see that the majority are early. All right, and this is going through the years. Now, I'm gonna I didn't put 2023 up yet because it's not finalized, but we've had a little bit of a blip in advanced cancers. And what I can tell you is Dr. Chasen and Dr. Spivak and I have talked about this. We've looked at some of this, and what we're finding is, and this is why today is important as a starting point for all of us. A lot of these patients who are coming into the program, having their first scan, and they're finding stage 3, stage 4 cancers. These are people who 10 years ago were eligible for lung cancer screening, and we had it at Griffin Hospital. Okay. They just got enrolled now. And that's why we're saying, let's get the word out there. All right. Because a lot of people have been floating around out there for years, could have been in this program. And who knows? Because the biology here can be very unpredictable. But, you know, you think that for some of these people, if we started them 10 years ago, maybe we would have found this when it was just a little tiny thing like I'm going to show you. Okay. So this is a great patient to talk about. This is a woman who goes back early in our program, so this was back when you could self-refer. She actually came into my office and said, I'm worried. Okay, I've got children. I used to smoke, but I quit. And both of my parents died of lung cancer. Okay, asymptomatic, normal, because that's what you have to be. Okay, and this is her CAT scan. So, you know, I'm not gonna put you all on the spot. Where's the lesion? So this, let me get the pointer going, hold on. There you go. So this is it right here. Okay, look at that. You're not gonna know about that for years. Okay, so she's in our lung, right? That showed up, right? Everybody-
Yeah.
All right, because I know the arrow keeps disappearing. So the program, the algorithm tells us if you have that, get a PET scan. And this is the reading of this patient's PET scan. It was a low level of activity, but the radiologist alerted me and said, this is suspicious. So I said to the woman, when you're in lung cancer screening for a reason, let's just take this thing out. So we take it out, and sure enough, this is her tumor. This is an adenocarcinoma. It's a well-differentiated adenocarcinoma. So it's an early process here of lung cancer. Now here's where this gets interesting. So her final pathology showed her to be stage 1A. And remember, I told you there are subgroups here with a 90% cure rate. So she stayed with me 5 years. I give her the good news. Congratulations, you cured. All right. Let's put you back into lung cancer screening because you're still eligible. Well, sure enough, 2 years later, she comes in with a new nodule on the right side now. That turns out to be cancer. And she wasn't a candidate for the lobectomy surgery, but she was a candidate for surgery. And she's now 2 years post-op with no evidence of disease. So that's twice for this woman. All right. You saw that speck of a thing there.
Does that happen a lot?
It does. It's funny. And and again, I want to, well, a lot is relative.
Yeah,
It
I
happens.
mean, more
It
than
happens.
10% of people, would you say?
I wouldn't say that, but here's the thing.
Because,
Well,
you know, with
It's gonna
breast,
happen more as more.
yeah,
people
with
enroll in the
breast,
program.
we
That's it.
do.
There you go. What we're seeing, you know, so 20 years ago, lung cancer, you know, it was a stroke of luck to find somebody that we can cure.
Right.
They're in a car accident and they do an X-ray. Oh, by the way, you know.
Yeah.
So years ago, when I was in training, we didn't have a lot of 5-year survivors, so we didn't know what was going to happen. But we've come to realize that the number one risk factor for lung cancer is a personal history of lung cancer. Okay, so as people are being cured, now it's even more important to keep an eye on them because that is their own inherent risk for a second tumor. And when that happens, we apply the same, it doesn't mean, well, forget it now, you have another one. No, we take the same criteria. Remember, this is not a recurrence, this is not a continuation. They're cured.
Yeah.
And now they've got a new tumor.
Yeah.
All right, so it makes that even more important to keep them in the program.
Now, a patient like that, do they continue with any chemo or radiation after you take that
No, this was
tumor out?
early stage lung cancer means surgery, you know, we get a 1A. Okay, stage 1A means surgery and observation. There's no indication. It's been proven that chemotherapy, radiation therapy don't change anything.
And you do the scan then every year?
Yeah, well,
typically?
after surgery, on a little different schedule, we do every 6 months for the first couple of years, but then annually. So this woman is going to be with us.
Just like
Correct.
mammograms.
Yeah,
Okay.
exactly. Okay. Now, we have some time. So let me just show you again, some of this is bragging. Okay, yeah.
I
sorry.
suppose you may get to it, but you talked in the initial studies and everything, as being eligible for the screening is obviously a history of smoking. Are there
Yeah.
other categories of people who?
No, it's strictly related to smoking.
That was one of my.
Yeah.
questions.
Okay.
Now-
Secondhand smoke. is that-
Now, yeah, so secondhand is not part of it.
Cancer elsewhere, that's typical, no, okay.
So again, you have to remember, there's a difference between screening someone and working them up. Okay, so
Yeah,
if someone has a history of something that could be particular for lung cancer, then they should be worked up, and that might include a CAT scan of the chest. This is about, hey, we've got no other reason to think about it,
okay, I got you.
okay, except for the fact that you either are smoking or have smoked. Okay. So we've done a lot, so as a benefit of our affiliation with Quinnipiac, I've had a number of projects through the years that have fallen out of our lung cancer screening program. And one of them that I just want to talk to you about, because again, this goes back to my whole thing of, you know, these people need to go into this in the right frame of mind, okay? I'll give you the background on this study that we did. We had a patient early in the experience who had a very bad experience with lung cancer screening. She didn't end up having lung cancer, but she had a finding and it triggered a whole bunch of emotional and behavioral problems as a part of being brought in and worked up, okay? And I'm sitting there in the office thinking, oh, this is great. I reassured this woman she does not have lung cancer. Well, I didn't realize that I had triggered a whole host of other things. So I said, you know, okay, we're saving lives. We know that. All right? But are we ruining lives? So I came up with this project that I did with Nathan Dembowski, who at the time was a Quinnipiac medical student. He's now, he went on to do an emergency room residency at Yale, and he's in the, I think he's in Massachusetts as an ER physician. I came up with this. Let's look at patient wellness related to lung cancer screening. So this was something that we presented at the Plain Tree Conference, and then we presented it at CHEST, which is the largest chest medicine conference in the world. It was accepted for presentation there. So what we decided was, this was early in our experience, and I said, Nathan actually did this study in the summer of 2015. He was on a summer break from medical school. So I said, let's get people early in our program. We'll choose them randomly. And let's make sure that they've had a few months to be part of the program so that they can figure out how this has affected them. So we did a telephone survey and we enrolled 101 patients in the program. And in fact, 3 of those patients were actually found to have lung cancer while they were as part of our program, okay? And Nathan had a questionnaire for them, and I'll put this up there just to show you that it was very generic. It was simple questions. Do you feel you've benefited? We didn't define any of this for them. Do you feel you've benefited from this? Okay, do you feel that you've been negatively impacted? Yes or no? Okay, how anxious were you about lung cancer before you started? How anxious are you about lung cancer now? You know, what has this done for you emotionally, you know, mentally, all that. And then we talked to them about their, how it's affected their smoking. So these are our results. So of the 101 patients, 95 of them felt they had benefited from this. Okay, but what I thought was great was none of them felt that they were, as reported by themselves, none of them felt that they were negatively affected by it. So that's great. Right. And then we asked them about their anxiety level, and what we found was that participating in this program sort of helped with their anxiety. They were less anxious after being a part of this. So we were providing them with some degree of reassurance. So we knew that all of these patients were thinking, maybe I've got lung cancer. And then they get that scan, but remember, we have to remind them that, okay, this is just a point in time. See you next year. All right. But we're helping them to feel better about themselves. Okay. Interesting is that, so this is a little complicated. I'll just give me a minute to show you. On the left is former smokers, and on the right is current smokers. So current smokers did not get that same relief. Okay. Which emphasizes that smoking cessation is imperative here, okay? And in fact, we did find that patients were, of those patients, so 53 of the 101 smoked when they started in the program. We found that 5 of them had actually quit, but most of them were saying, I'm smoking less. And most of them said that they were more likely to quit than less likely, okay, or not likely. And when you look at quality of life, and again, this is self-reported, the majority of them said, no, it hasn't really changed that. But if they did see a change, it was in terms of improvement, okay? So our conclusions from this were that lung cancer screening confers a reduction in anxiety about lung cancer, that it increases a patient's perception of their quality of life, that it gives us a teachable moment for smoking cessation. So bringing them into lung cancer screening allows us to hit them with this and say, hey, you know, and we've got something here to help you. Patients perceive it as beneficial, and within the group of patients that we studied, there was no negative impact. So I think this was really, and this was very well received. I got a lot of good feedback on this. So again, this is what we can do with it. So questions, comments, thoughts?
So if somebody goes through your program and keeps on smoking, or as you said, lessens it.
Yeah.
You still see them yearly and you still say, stop smoking,
Yeah.
stop smoking. And
Yeah, we don't dismiss them because, like I said in the beginning, you know, these people, they need to be embraced.
What's the threshold for eligibility in terms of their smoking?
So age 50 to 80,
50 days.
okay, age, and they have to have a 20 pack year smoking history. So packs per day times number of years has to exceed 20, and they either are currently smoking or quit within the last 15 years.
15.
Okay, so if they quit
20 years
16
ago.
years ago, now we're hoping that 15-year retrospective thing will go away. Hopefully there'll be enough pressure to get rid of it. So, you know, this is Griffin.
Nice.
We can do it.
Are there any questions online? Anyone have any questions? Any of our virtual folks have questions, comments?
Comment, doctor, I just returned from the Cape. My sister fit the bill that you just described, and she did have lung cancer. She was treated. She did the 2 years post-op that you described. But the thing that hit me is your point that likely recurrence. If he's not out of the woods.
Well, you want to get through that first 5 years.
Yeah.
To declare them cured. And what I do with my patients is, as we go along, I say, okay, you're gonna see a gradual shift from me. We get to 2 years, I can't declare you cured, but if there's nothing suspicious, you're probably cured. And now we're gonna start to emphasize, you're at risk. Don't get depressed, don't get demoralized, but we gotta keep an eye on you. We're gonna have a celebration when you're 5 years, but we're not gonna throw you out there. We gotta keep an eye on you. And I've cured people 3 times.
Yeah.
I've cured, and not with lung cancer screening, but I've had patients with 3
Recurrence.
primaries. Okay,
Yeah.
no, primary, not recurrent,
Primaries.
primary. So 1 cancer,
Yep.
2nd cancer, 3rd cancer. Okay, so we can't forget about it. So, and I've always used, and you heard me use the mammogram. You know, people have, because that was always a hard thing in the beginning.
Yeah.
People come in, they have their scan, we say it's okay, and they're like, oh, okay, good. No. Next year, but you told me I'm good. There's nothing there. No, you're good now. Okay, you're good now. And again, I use the mammogram.
Yeah.
Analogy where, I say, no, a woman gets that good news, okay, but they understand that I make my appointment now for next year. So,
Does this pick up just tumors or, so my
I'll
mom,
let Joanne
yeah,
answer
'cause my
that,
mom
because
had
she
lung
has the
cancer, but
numbers.
she never had tumors. Hers was
I don't even know how to describe it, but
So they show up metastatic.
it was in the lower
Yeah.
bases of her lung,
Yeah.
but it wasn't an actual lesion or a tumor. It was
Yeah.
in
A
the
nodule.
tissues.
Yeah, they
and
call
stuff.
them the nodules. That's what they look for when they do the scans.
But we've had other fallout from this
Yes,
program. And
we
Joanne
found-
can give you the ideas.
Yeah, we found kidney cancers, lymphomas, thyroid cancers, bladder.
Pancreatic, we've had, so you know how awful pancreatic cancer is.
Does it
Right.
spread? Or,
Because-
No, these are primary tumors.
so when you're doing a CAT scan, it's showing, you're not just looking at the lung.
Correct.
Yes,
They scan from the
Yeah.
neck
So you
down
get
to
you get the other organs.
You just happen to see it, basically, yeah.
we found breast cancer.
Yeah.
The radiologist will say, the lungs are good, but there's something there in the breast. And then we bring them in and they get a mammogram and they get a biopsy and Dr. Barajas takes over.
Mhm.
So do you know offhand the numbers? It's not a negligible number of other cancers that we
That are
discovered.
discovered.
There's
Yeah.
probably at least 10 to 12 of
Mhm.
other
Yeah.
cancers that were
Yeah.
discovered.
Do you think you'll ever get to a point where this is like part of like when we go for our mammograms, you're gonna go for one of these every year?
If you have that
Part of your
history.
physical, yeah.
It's not gonna apply for everybody. It's not gonna, it's not gonna be like the mammograms.
Okay.
Because this really is so smoking dependent.
Right.
And you would just, we wouldn't have the resources to do this.
Mhm.
And it wouldn't be effective. You'd end up doing more harm than good
Mhm.
if you're screening everybody. Because remember, I told you, 1 in 4 patients have something, but most of that is not cancer. But along the way, you're gonna maybe do biopsies and surgeries that have their own risks and consequences that you could say were unnecessary.
Okay.
If you start screening everybody, then you're gonna have a lot more of those things. So you have to be really careful here who you screen, and it's hard. And Joanne can tell you that it's hard when, we tell the patients, okay, you've aged out, or your smoking history is such that you're out of the process now. That doesn't mean that you're not gonna have something ever.
Mhm.
It's just a matter of applying this to a population, okay? We treat individual patients with our data from the community at large, and sometimes those two things aren't identical.
Interesting. Lung cancer in Connecticut, how does that fit within the national average? It's like when I talk breast cancer, it's like, okay, Connecticut's number 2 in the United States for breast cancer. Do you have any?
I don't know, I'm not sure. I really don't know that. I think that, there definitely is a regional component to this. You go to West Virginia, coal mines and all that
Right.
kind of stuff. I don't know. I don't know that.
Okay, I was just wondering.
I think a lot of it, so there's another side to the breast data, is that we are on a national level. Connecticut is a very sophisticated state, okay? We have, think about it, Ivy League and, high level community in terms of knowledge and information and intelligence. And, so people really,
People get their mammograms.
people know about this.
Yeah.
Yeah.
You know what, I need, the switch might be off, it's saying,
Anyway, that's fine. Yeah, I'm done anyway, so
I
yeah.
have one quick question.
Sure, yeah, no.
The massive inflation price of cigarettes, I mean, they're $20 a pack. Has that had any impact on?
So if and I'm not, this is beyond this, smoking in this country has done this, but I'm telling you, it's this now. It's about 20%, and it's not going down anymore. So there is always gonna be this group of people who are gonna.
20% of the adult population?
About, yeah. Remember, that's national.
That's not.
But again, there's regional difference.
Yeah.
And again, like I said, remember what I said earlier, these people are marginalized. You may not even know they smoke,
Correct, yes.
because you can't smoke here. go hide,
Right.
go hide and smoke.
Yeah, I find that, yeah.
And so number one, that's the message from us, us, what I mean.
Yes.
That's the message. And number two, it's hidden. There's people out there you might not even realize.
Yeah.
Okay?
I think Melissa online had a question.
Yeah.
One thing I just wanted to let you know, if you have any material promoting this, we have a community bulletin board for nonprofits. So if you want to work up a slide, we'd be happy to put that on our channel. And
Great.
we don't have demographics on our channel, but I tend to think it's older people. So we might be reaching the people that you're looking for. My question was, though, if somebody comes into your program and let's say they quit smoking 10 years ago and you screen them, once they hit that 15-year, if they're clean, do you kick them out of the program? Do you stop screening them because they've passed, they don't qualify in that term anymore?
And again, this is all population health. You come to a point where your benefit to the community at large goes away. They think. We don't agree, but the experts, the people who make policy,
Yeah.
which means the people who decide whether or not they're gonna pay for it,
Yeah.
have decided that if you quit 15 years ago, then the benefit to society as a whole is not worth it. We're gonna spend too much money and have too many problems for the lives that we might save. It's a hard thing to digest, but it's the idea that, we have to treat patients with populations in mind.
But if the insurance companies pay, then we could maybe eliminate some of that.
Yes and no, because again, it's so someone, 45 years old who says, I'm nervous about getting lung cancer. Well, we can't really screen those people because
No,
we're
not
gonna-
right
yeah,
now
yeah.
you can't, but hopefully in 10 years.
Private pay it. I mean, it's just
Yeah.
insurance won't cover it or you won't do it. What's the difference?
Well, again, there's indications for things and just scanning somebody because they're nervous
They're nervous,
isn't always
no, they're not.
isn't
No,
always
it's
an
not.
indication.
Yeah. I got
That's the thing,
I got
it's tough, so.
Thank you so much.
Thank you.
All right, great.
You can spread the word and hopefully doctors' offices start to tell their smoking patients that this exists and, we can get those numbers. and
Well, again, and I think
Your
it's,
rates up.
I think the other side of it is getting people to go in and say to their doctor, why didn't you tell me about this or put me in this, so it's and getting our friends and families.
Mhm.